Welcome back to the Deep Dive. Grab your loops because today we are doing a really meticulous high-resolution analysis of the 3D geometry of the knee joint.
Yeah.
Our mission is it's intensely focused and highly technical. We're dissecting the source material on this novel computational work pioneered by Mohammed Mahfouz on the intrinsic shape differences between ethnic populations.
And the goal here is to give you, the orthopedic learner, the real foundational knowledge you need for the next generation of implantable device design.
This deep dive lands us squarely in the operating room.
It really does. We're here because the whole concept of a single universal implant design for total knee arthroplasty for TKA is just fundamentally flawed.
Right.
It ignores decades of known anthropological and morphological variation, and that leads directly to, suboptimal outcomes, instability, and a lot of patient dissatisfaction when we try to fit a component that's optimized for one group into the anatomy of another.
And the genius of the work we're analyzing is in its sophistication. It moves beyond just, gross measurements and applies these ethnic-specific statistical bone analysis.
It's a computational shortcut.
Exactly. A shortcut to understanding why that standard off-the-shelf component so often fails to restore true kinematics. If you try to force a one-size-fits-all implant, you're just fighting the patient's intrinsic geometry.
You are.
And that leads to kinematic stripping and eventually early mechanical failure. It's like trying to torque down a delicate titanium screw with a cheap, ill-fitting hex wrench.
That's a perfect analogy. It's precisely that fight against the native geometry that causes so much trouble interoperatively. I mean, when you're in there managing a flexion gap that's asymmetrical because of some unrecognized difference in the condyles, or you're dealing with patellar tracking issues because the component rotation is based on some average generic knee.
That's when this data becomes absolutely critical.
It becomes surgical gospel. We have to abandon that brute force insertion mentality and, start recognizing these geometric variances at the sub-millimeter level.
So let's unpack the foundation first. What did we, as a surgical community, already know about these morphological variations before we had all these advanced 3D atlases and computational tools?
Well, we've known for decades that ethnicity plays a huge role in lower limb morphology.
Right.
Historically, the most obvious differences, the ones that, screamed for component redesign first, were between Asian and Western populations. The variation there was it was too dramatic to ignore.
Yeah, that makes sense. If you look at the established literature from groups like Chu and Yip, the findings on the Chinese femur are really stark.
They are.
It's typically more anteriorly bowed, often presents with a greater degree of external rotation, and importantly for anyone doing intramedullary nailing, it has smaller intermedullary canals and significantly smaller distal condyles compared to femurs in white individuals.
Oh, and if you try to use a standard IM nail designed for a larger Western canal, you're in for a bad day. You either run into sizing problems or, worse, you end up violating the cortex.
And that's just at the macro level.
Exactly. When we think about TKA, those smaller distal condyles, they fundamentally change the fit. We're talking medial lateral sizing, the critical anterior flange placement. A lot of those early Western implants just overhung the Asian knee laterally, causing all sorts of soft tissue irritation and pain.
But the sources we're diving into today, the Mahfouz research, they take a really critical, nuanced look at modern Black versus white Americans.
Yes.
And while the gross differences might not be as immediately obvious as that Asian versus Western comparison, the intrinsic structural and density differences are, well, they're immense and highly relevant, especially for load bearing.
Absolutely. When we talk about bone quality, the profile of Black populations is structurally distinct. I mean, they consistently demonstrate thicker bone cortices and narrower endosteal diameters.
And the big one.
And crucially, they have significantly greater bone mineral density, or BMD, right across the board. This isn't just some minor variation. This represents a completely different mechanical strength profile.
And this inherent structural robustness has some pretty significant clinical consequences that go way beyond just arthroplasty, right?
Exactly. When you look at the work of Mikhail and Theobald, the picture becomes crystal clear. That combination of higher BMD and a shorter hip axis length is believed to be highly protective against mechanical failure. It explains the much, much lower prevalence of osteoporotic fractures, particularly hip fractures, in Black women compared with white women. The bone itself is just structurally engineered to resist failure more effectively.
So that's crucial context, because when we put an implant into a bone with thicker cortices and higher density, The whole interface mechanics and long-term fixation potential are inherently different.
It provides a necessary counterpoint to focusing just on shape. You have to
Ah.
consider the material properties, too.
Okay, so let's look at the specific population this study targeted. Modern black and white American males. The researchers pulled together 223 lower limbs, 183 white, and 40 black.
Right, and this is where we need to put on our critical eye, as residents and surgeons reading a paper.
Okay.
While 223 is a solid total sample size for a high-resolution CT analysis, that distribution N equals 40 for the Black American cohort versus 183 for the White American cohort, it demands some caution, especially when we're interpreting p-values.
That's a key point. Are we risking a type 2 error here? I mean, failing to find a difference that does exist just because the statistical power of that smaller group is limited?
Especially for measurements where the difference might be slight but still clinically relevant.
Right.
It's a very real risk, and the authors do acknowledge that. However, their inclusion and exclusion criteria really bolster the integrity of the sample. They specifically excluded bones with severe osteophytes, post-traumatic deformities, or other abnormalities.
So they were trying to isolate just the pure, intrinsic, healthy, anatomical shape variation.
They were looking for the baseline genetic geometry, not acquired pathology. And that meticulous selection process is fundamental to the validity of the atlases they built.
So we start with this incredibly high-fidelity CT data, 0.625 millimeter cubic voxels. How do they translate this immense volume of raw data into reliable, automated comparative measurements? This is where it starts to diverge from traditional calipers and rulers.
This is where the magic happens, the computational framework. They're using these ethnic-specific statistical bone atlases, and they combine two major statistical techniques we need to be familiar with: principal components analysis, or PCA,
Okay, PCA.
and multiple discriminant analysis, MDA.
PCA allows you to take a data set with hundreds of variables, all these microscopic points on the bone surface, and distill them down to just a few key dimensions that account for most of the variance, right?
Precisely. It's a mechanism for dimensional reduction and for describing the global shape. And crucially, it allows us to isolate shape from size. Then MDA steps in to test the statistical separation between the groups black versus white based on these reduced components. And that's all confirmed through t-tests and power tests.
So the core objective isn't just statistical curiosity.
No, not at all. It's to generate data that can be programmatically integrated into CAD software for prosthesis design, into sophisticated preoperative planning systems, and eventually into real-time intraoperative navigation. We need robust, repeatable surgical data.
All right, let's do a deep dive into the digital mold itself, the statistical bone atlas.
Yeah.
For those of us who haven't built one, how should we understand its function and its central importance to achieving what you called point correspondence?
Think of the bone atlas as the platonic ideal of the bone for that population. It's a standardized, average 3D template mesh.
Okay.
Initially, these atlases were developed mostly for automatic image segmentation, getting the computer to reliably trace the outline of the femur in a sea of CT noise. But here, they're repurposed to capture the primary modes of shape variation within a specific population.
And the critical requirement is that every single point on that template mesh has to correspond mathematically to a homologous point on every single patient's bone model in the study.
That concept of homologous points is the entire ballgame.
Right.
If the point representing the center of the lateral femoral condyle on subject A doesn't align perfectly with that same point on subject B, then any statistical comparison of length or curvature is just meaningless noise.
And I imagine achieving that correspondence is computationally intense.
Extremely. If you look at the flowchart for atlas creation, it's figure 16.1. It outlines a 4-step process. You start with simple alignment, matching the centroids and pre-scaling the template mesh to the target bone model. That's just getting things in the right ballpark.
Just a standard registration setup.
Next comes the rigid alignment phase, and that leverages the iterative closest point, or ICP, algorithm. ICP finds the best possible rigid transformation, so rotation and translation, to minimize the distance between the two surfaces.
But it's limited, right? It's just a single rigid block movement.
It is. It gets the knee in the right orientation, but it can't account for the fact that one knee might be wider distally or bowed differently in the shaft.
Okay.
So to account for those linear differences, we move on to the general affine transformation. This step introduces 12 degrees of freedom: rotations, translations, uniform scaling, non-uniform scaling, and shear.
So that pushes the linear matching capability to its absolute limit.
It does. If the new bone is longer or wider in a predictable linear way, the affine transformation handles it beautifully.
But I'm guessing linear transformation still struggles with those local high curvature areas,
Yeah.
like the fine geometry of the posterior condyles or the complex, irregular shape of the intercondylar notch.
And that's the crucial novel contribution of this methodology. This is where the surgical relevance skyrockets. The nonlinear iterative warping approach. Linear matching fails catastrophically in areas where there's high local curvature change, which is exactly where rollback happens during flexion. If you just rely on an affine transformation, you might get a great fit for the shaft, but the critical articular surface geometry is misaligned by a millimeter or two.
And a millimeter of misalignment on the posterior condyle translates directly to a catastrophic change in the instant center of rotation during deep flexion.
It absolutely does. The iterative warping algorithm addresses this by applying local, non-uniform deformations. It's almost like mathematically stretching and shrinking the template mesh point by point until it perfectly conforms to the target bone surface.
Wow.
The researchers use these smoothing algorithms that change how they weight different geometric vectors early versus late in the process, allowing greater local expansion of the template into complex surfaces. This process is how they achieve true sub-millimeter point correspondence across 99% of the bone surface.
And the resulting surgical precision is just phenomenal. Less than 1/4 of a millimeter surface accuracy in the manual segmentation. That yields these highly reliable automatic measurements with coefficients greater than 0.97.
That level of reliability is what moves this data from a theoretical paper to a clinical application. It means we can trust that a measured difference, even one as small as a fraction of a millimeter, is a true biological variance and not just measurement noise.
Okay, so let's go back to leveraging this precision with PCA.
Right.
We established that PCA reduces complexity, but how does that separation of size versus shape work mathematically, and why is that so important for implant design?
So as we said, the first principal component, PC1, accounts overwhelmingly for scale, size.
Right, short patients, tall patients.
Exactly. If you're designing a knee implant, you have to cater to that range of sizes. But if you were to design based solely on the average shape and size, the real differences in shape between populations would get masked by the sheer variability in patient stature.
So by normalizing all the subsequent principal components against PC1, they mathematically just remove the influence of size.
They do. And you're left with the pure shape modes.
So we're designing for the inherent architecture, independent of the patient's height.
Yes. That's critical for creating a modular component system that fits the morphology, whether it's a size 3 or a size 7 component.
And this automated system let them measure 99 femur and 23 tibia variables reliably. That scale would be impossible to do manually.
Oh, it would take hundreds of man-hours and introduce unacceptable human error. The statistical atlases provide that bedrock of homologous points that makes this mass automation possible.
And the practical visualization tool that makes all this digestible for us, the feature finder algorithm. This is the heat map, right? The thing
Yeah.
that shows us where the battle lines are drawn.
That's the surgical cheat sheet. If you look at the color map in figure 16.9, the feature finder applies this innovative statistical treatment that highlights regions with the maximum morphologic difference between the groups.
So where you see red.
Where you see red, that's where you have high discrimination, where the differences are largest. Where you see blue, the groups are essentially the same. This immediately tells an implant designer where to spend their R&D budget focus on those high variance red zones.
Okay, let's transition now to the core findings, starting with the distal femur. We should probably first just quickly review the critical axes the researchers used, as this is our daily surgical vocabulary.
For sure. We begin with the transepicondylar axis, TEA. This is the anatomical axis we all use to define femoral component rotation. It connects the most lateral prominence of the lateral epicondyle and the most medial prominence of the medial epicondyle. You can see it in figure 16.2.
It's the closest thing we have to a reliable fixed rotational reference.
Even though that's been debated, yes.
Next, the knee center, K.
K is the distal endpoint of the mechanical axis, MA. The MA, of course, defines alignment from the center of the femoral head down to the center of the knee. K is specifically located at the intersection of the TEA and the mid-sagittal plane of the distal femur.
And the anteroposterior, or AP direction. This is the reference for determining the AP size of the condyles.
Right, so that vector is mutually perpendicular to both the MA and the TEA, and it originates at K. It's important to note the researchers confirm this AP direction is similar to the clinically relevant white side line, which we often use intraoperatively to set rotation when the epicondyles are hard to feel.
And we use these definitions to measure key condylar dimensions, shown in figure 16.3. Anterior medial lateral width, AML, posterior medial lateral width, PML, and the AP length of the medial NAP and lateral LAP condyles. So let's dissect the results in table 16.1. First up, the size difference. Black American males have significantly longer femurs, suggesting they need larger components overall, which aligns with the general scale differences.
Right, and the femoral shaft curvature, the SC, was significantly different, P0.01. Black American males exhibited straighter femurs, a larger radius of curvature. This affects everything. If you're using an intramedullary referencing system, a straighter femur changes how the jig sits and potentially influences the angle of your cuts. It demands implants with a less intrinsic anterior bow.
Okay, what about the medial lateral, the ML dimensions?
Here, Black American males showed a trend toward narrower knees, a smaller TEA width, but the p-value was only p equals 0.10.
So given the smaller sample size for the black cohort, this could be a genuine difference that just failed to reach high statistical significance.
That's a key interpretative point for any resident reading this data. The sample size really limits the confidence.
But the true statistically robust shape difference, the clinical takeaway, was in the AP dimensions of the condyles. The feature finder in figure 16.9 is just screaming about it.
It is. The difference is stark. The lateral condyle length in the AP dimension, the LAP, was significantly longer in Black American males, P0.01.
And crucially, the medial condyle length, the MAP, showed no significant difference between the populations. P was 0.32.
And that is the whole thesis of the geometric variance. You have a long lateral condyle sitting next to a medial condyle of a standard length.
So that asymmetrical posterior condylar offset a longer lateral AP length relative to the medial. That is the definition of the morphological difference. This creates the distinctive trapezoid-shaped knee in Black American males.
Exactly, versus the more square-shaped knee seen predominantly in white American males.
And the clinical implications here are immediate and potentially catastrophic if you ignore it. You use a standardized square profile femoral component on a trapezoid knee. What happens?
You've got two major risks. First, you risk undercoverage laterally, especially in flexion, because the implant won't extend far enough posteriorly. That leads to instability, a potentially loose posterior lateral corner.
And the second risk?
You risk overstuffing the flexion gap medially because the component is thicker than the native anatomy demands. And that leads to poor flexion, difficulty balancing, and increased forces on the patellofemoral joint.
Which results in patellar tracking issues.
Absolutely. It forces the surgeon to compromise the flexion gap balance. They might have to excessively resect the tibia or adjust the soft tissue tension just to accommodate an ill-fitting geometry. The trapezoid shape fundamentally affects how the joint rolls back in deep flexion.
Let's elaborate on that mechanism of rollback by talking about the curvature analysis. The researchers defined the condylar profiles, medial, lateral, and sulcus, by intersecting the distal femur with planes rotating in 10-degree increments around the TEA.
Right, and the curvature model in figure 16.10 found that the profile can be mathematically approximated by 4 distinct radii, C1 through C4.
And this 4 radii structure was consistent across both ethnic groups. So the fundamental design of the human knee is the same.
The blueprint is the same, but the values of those radii C1 through C4 were statistically different between the populations. You can see that in figure 16.11.
So it's a difference between two engines built on the same blueprint, but one is using thicker, more robust components.
That's a great way to put it. The fundamental structure is conserved, but the specific geometry that dictates motion is unique.
And there was a specific observation about the relative flatness of the lateral profile compared with the medial profile in figure 16.12.
Yes. The lateral condyle, being responsible for the majority of the posterior translation, the rollback in deep flexion, relies heavily on that precise geometry. If the lateral condylar curvature profile is flatter, as suggested here, it means the kinematic path is subtly different.
And the implant must accommodate that to allow for natural, non-constrained motion.
It has to. It's the difference between trying to slide a disc versus rolling a cylinder. The curvature dictates the instant center of rotation. A mismatch means restricted motion or accelerated wear.
Okay, so moving discally to the proximal tibia, let's see how the tibia mirrors the femur's anatomy. We're looking at table 16.2.
And overall, the trend remains. The tibia of Black Americans are generally longer and more robust, consistent with that higher scale factor, PC1, and the greater bone density we mentioned earlier.
But interestingly, the mean medial-lateral width, the ML, of the tibial plateau was only marginally longer.
Yeah.
It didn't achieve statistical significance, p 0.41.
Again, possibly reflecting that sample size limitation.
Right.
But the truly significant correlative finding was the lateral plateau height, the LPH. That was highly significant, p 0.05.
So this is the joint congruence speaking to us.
It is. The significant height and AP length difference found in the lateral femoral condyle, the LAP, is perfectly mirrored by a significant difference in the lateral tibial plateau height.
So the trapezoid shape isn't just a femoral phenomenon, it's a joint-wide characteristic. The proximal tibia accommodates that longer, flatter, lateral femoral condyle with its own distinct lateral height structure.
It has to. And the feature finder in figure 16.9 also highlighted significant shape differences around the tibial tuberosity area and the tip of the medial malleolus,
Surprisingly more so than the main load-bearing plateau surfaces.
which suggests that the highest variability is found in these peripheral, less articulated areas. And that leads us directly to one of the most contentious issues in TKA, rotational alignment.
The dreaded tibial alignment landmark problem. I mean, as residents, we're all taught to set the tibial implant rotation along the vector, connecting the tibial tuberosity and the posterior cruciate ligament, or PCL, insertion.
And this study, along with a lot of prior research, just exposes that approach as deeply flawed.
It's like trying to navigate in a fog bank.
Trying to align a rotational component based on the tibial tuberosity is like trying to dock a massive oil tanker using the sound of a buoy that may or may not even be there. The tuberosity is just highly variable in its morphology and its position relative to the true rotational axis.
The clinical caveat here is enormous. The sources reinforce that finding from Siston and others back in 2006. Using the tuberosity PCL axis for alignment can result in a staggering 27-degree standard deviation.
27 degrees.
That's the difference between a textbook alignment and catastrophic rotational malalignment.
27 degrees of potential error. That's just unacceptable variability for a procedure that's aiming for high precision. It means the tuberosity is an unreliable landmark, full stop.
It is?
If you have to accept that much potential error in your baseline landmark, the final stability of the knee and the tracking of the patella are inherently compromised from the start.
And the feature finder showed a red zone high variability right around that tuberosity area, which confirms computationally what surgeons have observed empirically for years.
It does.
I remember struggling as a resident, just trying to visually triangulate that axis in a messy field. It's such a subjective measurement based on a highly variable anatomical structure.
Exactly. When you think about it, the tip of the medial malleolus, despite being a smaller feature, was statistically more significant in terms of variation in the computational model. Yet we rely on the bulky, variable tuberosity for rotation.
So the 3D Atlas methodology is effectively telling us to stop trusting the most common but least reliable landmarks.
Yes, it's advocating for using the fixed, repeatable geometry that these atlases can provide.
Okay, we've established the static differences. The straighter femurs, the trapezoid shape,
Wow.
the highly variable landmarks.
Well,
Now, how does all this sophisticated morphologic data translate into designing an implant that restores dynamic functional motion?
the key shift is moving from absolute measurements to ratios. Ratios like MLAP, AML, PML, and crucially, LAPM-AP, they provide much greater insight into the fundamental shape geometry than individual lengths do. A ratio tells you the proportion, which is what governs the mechanical fit.
And these proportion-based ratios allowed the researchers to propose a massive conceptual leap, a classification system identifying 6 distinct types of femurs, which you can see in figure 16.1
This is a fundamental change in paradigm. We're moving away from the simplistic binary idea of an Asian knee versus a Western knee and acknowledging the immense morphological diversity within any given population.
So the goal is to design components for, say, a type 1, a type 3, or a type 6 femur, regardless of the patient's self-identified ethnicity.
Exactly. What conceptually differentiates these 6 types is that they are defined primarily by the ratios of the AP length versus the ML width and that specific LAPMP ratio.
So, for instance,
A type I might be a short, wide, square profile knee, common in the baseline population. A type 6 might represent an extremely long, narrow, highly trapezoidal knee. By classifying the patient's native anatomy into one of these 6 geometric categories, the implant designer can select a component designed explicitly to match that shape category.
ensuring appropriate posterior condylar offset and optimizing the flexion space.
That's the goal. And this moves us fully into kinematics, understanding the dynamics of motion. It's not enough to know the bone shape. We have to know how that bone shape interacts with ligaments and cartilage during motion. Figure 16.13 shows how critical soft tissue attachment locations, ligaments extracted from MRI data, are mapped directly onto the statistical atlas, demonstrating that complex interplay.
The ligaments are the constraints.
They are. The bone provides the mechanical path, but the ligaments dictate the stopping and starting points. To truly restore natural motion, the implant has to respect both.
And this realization has driven orthopedic research toward defining kinematically driven axes, moving away from simple anatomical references.
Yes. Let's detail the first alternative axis introduced in the sources, the cylindrical axis.
Oh.
Defined by Hancock and his colleagues, the cylindrical axis is purely functional. It's defined as a line equidistant from contact points on the medial and lateral condylar surfaces from 10 to 120 degrees of flexion.
So it's derived directly from the movement itself. It's where the knee actually rotates.
It is. And the second one is the spherical axis.
Right.
Defined by Tanafuji's work, the spherical axis is a line passing through the sunders of spheres fit to the medial and lateral posterior condyles. Since the posterior condyle curvature defines the initial stages of rollback, this axis is intrinsically linked to that specific anatomical geometry, those C1, C4 radii values we discussed earlier.
So we have the anatomical reference, the TEA, and then two function-driven references, the cylindrical and spherical. And the purpose of these functional axes is to accurately capture the instant center of rotation, the ICR.
Which is essential for determining how much the tibia will translate relative to the femur during flexion.
Right.
And the visual relationship shown in figure 16.110 is the ultimate proof that morphology is directly linked to kinematics. When researchers mapped the instantaneous axis of rotation during a deep knee bend, the spherical and cylindrical axes tracked that true motion path much more closely than the traditional transepicondylar axis did.
So this means that aligning a component purely on the TEA, which is the current surgical standard, is inherently forcing the knee to rotate around an unnatural or suboptimal path, especially in deep flexion.
That is the profound implication. If your implant doesn't respect the native geometry, those trapezoidal differences and those specific C1, C4 curvature profiles, you are forcing the joint to rotate around an artificial axis.
And that leads directly to impingement, increased polyethylene wear, ligament stretching.
And ultimately, patient dissatisfaction. The difference in morphology is the difference in motion. The trapezoid knee needs a trapezoid path.
The necessity here is clear. We need implant designs that better match the specific anatomic variation present both within and between populations.
Yeah.
The concept of a generic implant is just. It's obsolete in the face of this level of geometric detail.
And finally, we have to reiterate the necessity highlighted by Summerson and others. Clinical studies, including FDA trials, must incorporate representative population statistics.
Right.
If we design a type I square knee implant and test it exclusively on a type I population, we are completely failing the type IV or type V patient. This 3D atlas methodology provides the statistical muscle to ensure that representativeness is no longer a clinical aspiration, but a documented design requirement.
This has been a truly rigorous deep dive into the 3D computational morphology of the knee. We've gone from high-fidelity CT scans all the way to understanding the geometric mandate for personalized arthroplasty.
And to quickly summarize, we confirm that Black American males exhibit distinct morphological characteristics, including straighter femurs and, critically, a trapezoid-shaped knee.
And that's due to a significantly longer lateral AP condyle, the LAP, compared to the medial AP condyle, the MAP. This shape dictates a completely different kinematic path.
We also clinically validated the long-suspected unreliability of traditional landmarks, notably the tibial tuberosity, which demonstrates a potential rotational error of up to 27 degrees.
Relying on that much variability for high-stakes surgical alignment is just. It's no longer justifiable.
And most excitingly, these sophisticated 3D atlases allowed researchers to transcend simple averages. They defined at least 6 distinct femur types based on geometric ratios.
And they linked that specific anatomy directly to functional motion via kinematically driven axes, like the spherical and cylindrical axis, which are far more representative of the true joint center of rotation than the traditional TEA.
We started by comparing the standard implant to an ill-fitting wrench. Now we recognize that we don't just need a metric wrench. We need 6 different, highly specialized wrenches tailored to 6 different bolt heads.
And that raises the final provocative question for you, the orthopedic learner.
We have moved from one blueprint to 6 anatomical classifications based on bone alone. If we successfully integrate all the constraints, the soft tissue envelope, the cartilage compression, the validated kinematics, how many specific classifications will the future of implant surgery actually require?
Are we truly heading toward personalized N1 individualized patient-specific implants for everyone undergoing arthroplasty to achieve optimal function?
The morphology suggests we might have no other choice.
A demanding but necessary future for the device industry. Thank you for sharing these incredibly detailed sources for this deep dive.
My pleasure.
We'll catch you next time. Welcome back to the deep dive. Grab your loops because today we are doing a really meticulous high-resolution analysis of the 3D geometry of the knee joint.
Yeah.
Our mission is, well, it's intensely focused and highly technical. We're dissecting the source material on this novel computational work pioneered by Mohammed Mahfouz on the intrinsic shape differences between ethnic populations.
And the goal here is to give you, the orthopedic learner, the real foundational knowledge you need for the next generation of implantable device design.
This deep dive lands us squarely in the operating room.
It really does. We're here because the whole concept of a single universal implant design for total knee arthroplasty for TKA is just fundamentally flawed.
Right.
It ignores decades of known anthropological and morphological variation, and that leads directly to, suboptimal outcomes, instability, and a lot of patient dissatisfaction when we try to fit a component that's optimized for one group into the anatomy of another.
And the genius of the work we're analyzing is in its sophistication. It moves beyond just, gross measurements and applies these ethnic-specific statistical bone analysis.
It's a computational shortcut.
Exactly. A shortcut to understanding why that standard off-the-shelf component so often fails to restore true kinematics. If you try to force a one-size-fits-all implant, you're just fighting the patient's intrinsic geometry.
You are.
And that leads to kinematic stripping and eventually early mechanical failure. It's like trying to torque down a delicate titanium screw with a cheap, ill-fitting hex wrench.
That's a perfect analogy. It's precisely that fight against the native geometry that causes so much trouble interoperatively. I mean, when you're in there managing a flexion gap that's asymmetrical because of some unrecognized difference in the condyles, or you're dealing with patellar tracking issues because the component rotation is based on some average generic knee.
That's when this data becomes absolutely critical.
It becomes surgical gospel. We have to abandon that brute force insertion mentality and, start recognizing these geometric variances at the submillimeter level.
So let's unpack the foundation first. What did we, as a surgical community, already know about these morphological variations before we had all these advanced 3D atlases and computational tools?
Well, we've known for decades that ethnicity plays a huge role in lower limb morphology.
Right.
Historically, the most obvious differences, the ones that, screamed for component redesign first, were between Asian and Western populations. The variation there was it was too dramatic to ignore.
Yeah, that makes sense. If you look at the established literature from groups like Chu and Yip, the findings on the Chinese femur are really stark.
They are.
It's typically more anteriorly bowed, often presents with a greater degree of external rotation, and importantly, for anyone doing intramedullary nailing, it has smaller intermedullary canals and significantly smaller distal condyles compared to femurs in white individuals.
And if you try to use a standard IM nail designed for a larger Western canal, you're in for a bad day. You either run into sizing problems or, worse, you end up violating the cortex.
And that's just at the macro level.
Exactly. When we think about TKA, those smaller distal condyles, they fundamentally change the fit. We're talking medial lateral sizing, the critical anterior flange placement. A lot of those early Western implants just overhung the Asian knee laterally, causing all sorts of soft tissue irritation and pain.
But the sources we're diving into today, the Mahfouz research, they take a really critical, nuanced look at modern Black versus white Americans.
Yes.
And while the gross differences might not be as immediately obvious as that Asian versus Western comparison, the intrinsic structural and density differences are, well, they're immense and highly relevant, especially for load bearing.
Absolutely. When we talk about bone quality, the profile of Black populations is structurally distinct. I mean, they consistently demonstrate thicker bone cortices and narrower endosteal diameters.
And the big one.
And crucially, they have significantly greater bone mineral density, or BMD, right across the board. This isn't just some minor variation. This represents a completely different mechanical strength profile.
And this inherent structural robustness has some pretty significant clinical consequences that go way beyond just arthroplasty, right?
Exactly. When you look at the work of Mikhail and Theobald, the picture becomes crystal clear. That combination of higher BMD and a shorter hip axis length is believed to be highly protective against mechanical failure.
Uh-huh.
It explains the much lower prevalence of osteoporotic fractures, particularly hip fractures, in Black women compared with white women. The bone itself is just structurally engineered to resist failure more effectively.
So that's crucial context, because when we put an implant into a bone with